So this is the second half of asthma, and we're going to talk about corticosteroids. And so again, as I said earlier, there's two formulations of corticosteroids. There's an inhaled corticosteroid formulation, which are listed there, and then there's oral formulations, which are essentially prednisone molecules. Understand that corticosteroids are basically a 21 carbon type molecule, and they can be further subdivided into glucocorticoids and mineralocorticoids. The glucocorticoids are the ones that are the drugs that alter physiology, um, alter glucose metabolism, and are immunosuppressive. And so all these corticosteroids here are actually glucocorticoids, and mechanistically they operate through the glucocorticoid receptor. We'll talk about other drugs that are mineralocorticoids in another lecture. So as I said before, these corticosteroids operate through this glucocorticoid receptor, and it's essentially a drug receptor complex that forms that basically alters transcription of certain key proteins. And so a lot of these key proteins have general, very broad kind of physiologic uh, duties. And so, they can be immunosuppressive, they can be anti-inflammatory. A lot of these steroid binding elements, which are shown here, have the ability to alter other steroid hormones, thyroid hormones, vitamin D, retinoids, and so forth. And so, lots of things can be altered at the genetic level, which is why these drugs are, so helpful for not only asthma but for other diseases, as you'll soon see. And so, in terms of corticosteroids in relation to asthma, they're going to block the late phase of reactions that occur due to allergen, and you'll learn about these reactions in the next module, the host defense host response block. Whenever these allergens are physically present, they produce what's called airway hyperresponsiveness, and they basically kind of enhance inflammatory cell migration. And so when you supply corticosteroids, you reduce inflammatory cell migration, which again kind of reduces that airway hyperresponsiveness or hyperactivity. These corticosteroids are really the most potent and most effective anti-inflammatory type medication that's clinically available. The inhaled versions of these are really used for kind of the long-term control of asthma, whereas short courses of oral corticosteroids are often used to kind of get a really firm hold on a disease that's kind of quickly exacerbating. Some of these oral systemic steroids are also used for moderate to severe exacerbations of asthma, and then they're used as kind of an adjunct therapy to the beta agonist that we had already talked about, as well as the muscarinic antagonist that we had already talked about as well. So of course, corticosteroids have side effects. Side effects included, if inhaled, include hoarseness due to a local kind of sustained effect on the vocal cords. This concept that it's going to change the immunology of the local environment is well known, and so these drugs have the ability to produce what's called oral thrush, and this is what this looks like on this in this slide. And so essentially, it's candidiasis, which is a fungal infection within the throat cavity. And so we can tell the patients we can prevent this by, after they've inhaled the corticosteroid, they can gargle with water and spit. And so whatever residual steroid is actually left in the throat compartment can be washed out. And of course, if oral thrush does become a problem, we can treat it with topical antifungals, which are listed there, as well as systemic antifungals, such as fluconazole. The side effects to oral or systemic corticosteroid use includes adrenal or hormonal suppression. Excuse me. And so we can kind of combat that by co-administering a different drug called cyclosinide, which is an orally administered type pro-corticosteroid that's biologically activated only within the bronchial compartment. And so it really kind of bypasses this the throat cavity and really delivers only biologically active corticosteroids. within the anatomic compartment where the disease resides. And so that's kind of a novel approach to systemic steroid therapy. And so one of the things that we would like to kind of introduce is the differences between orally administered drugs and inhaled drugs. And so if a drug is administered orally, so one of these oral drugs could be, one of the corticosteroids that we had just learned about, it gets absorbed into the body and goes to the liver. And at the liver is where you see biotransformation, often called metabolism. But essentially the outcome here is that this drug becomes active at the liver. And so the liver metabolizes it, it biologically transforms it into something that is more often than not more active. And then that active drug elicits a change in physiology. And so that's where the mechanism of action comes in. It binds to those steroid responsive elements and elicits a change in physiology. And of course, at some point, this drug gets excreted. And so this is how an oral dose typically goes through the body. This is in contrast to an inhaled dose. And so in the inhaled dose, there's no kind of systemic distribution. You get a large portion of the drug going right into the lung compartment, and a large portion of the drug has a direct encounter with the bronchial epithelium, and then this is where these biologically active drugs reside, and that's also where the therapeutic approach to these drugs lies. I mean, the whole reason we're administering them is because the bronchial epithelium is essentially overstimulated and constricted, and so these active drugs have a deposition basically within this anatomic compartment. And just like the other drugs, they're excreted either through the urine, through the feces, or in this special case, they could actually be excreted through the lung compartment themselves. Okay, and so these are some of the different kind of pharmacokinetic properties between orally administered drugs and drugs that are inhaled. And so there also is a kinetic approach to this as well. And so this is kind of a log dose response curve in terms of plasma concentration over time of an IV dose compared to plasma concentration over time of an oral dose. And so you can see these curves are quite different. At this point, you get, the highest amount of drug essentially immediately deposited in this specific anatomic compartment. Whereas here, there's a little bit of a delay in terms of reaching the maximal therapeutic concentration. And so this is pretty standard of an oral dose. And so you give an oral dose and you have to wait at some time for it to work. And this is all orally administered drugs. This isn't just the oral administered corticosteroids. This is any orally administered dose. And so for this reason, typically in the emergency room, you give patients IV doses because essentially you get the maximal dose response within a minute or two of administering the drug. Okay. And so just to kind of summarize, there are some unique properties that are associated with inhaled drugs, and they are listed right here. And so one thing that's good about having an inhaled drug is that there's a reduction in side effects. So you don't have to give as much because you're not looking at systemic distribution of this drug. You're looking at kind of a localized distribution of this drug within a specific anatomic compartment, and that compartment is the lungs. And then from a delivery standpoint, you've got the bulk of the drug being delivered into the anatomical site where the disease lies. And so there can be some pharmacokinetic studies that allow you to kind of compare the effectiveness of maybe two different brands to see which drug gets into this compartment faster. But essentially those are kind of the unique properties of inhaled drugs that I just kind of wanted to introduce, at least in this early phase of this course. And then I also want to point out that a lot of the steroids have clinical uses beyond asthma, and so you're going to be very interested to know that as we go through this curriculum, there's going to be a lot of places where steroids are going to be used again and again, and so some of those mechanisms are described here. I also want to show your attention to this paradigm in terms of how asthma therapy is treated.